Kanski lecture series part 4, and in this part we are going to discuss about the changes in the glaucoma. In some cases it is not possible to be certain whether an individual optic disc is glaucomatous. The clinical findings and the result of investigations should be considered together to guide management. Glaucomatous damage result in a characteristic sign involving the optic nerve head, peripapillary area and the retinal nerve fiber layer. So basically we have to make every investigations and clinical findings before starting the treatment, because it is necessary to diagnose the glaucoma, and all of the factors are important like raised IOP. There can be an optic disc changes as well. So we discussed about the normal optic nerve optic disc in the previous lecture. In this lecture we are going to discuss about what the changes occur in the cases of glaucoma. So the peripapillary area is the area surrounding the disc is called the peripapillary area, and then there are retinal nerve fiber layer. So optic nerve head pathological cupping is caused by irreversible decrease in the number of nerve fibers, glial cells and blood vessels. A documented increase in the cup size is always significant. If an eye with a small optic disc and correspondingly small cup develops a glaucoma, the cup will increase in size, but even in the presence of a substantial damage may still be smaller than that of a large physiological cup. So basically it is trying to say that the optic neuroretinal rim is basically an important finding. It is following the Eisen rule: inferior is thicker than superior, then nasal, then temporal. So what happen is basically when there is a glaucomatous damage, there will be the thinning of this rim, and sometimes you know that a smaller disc have a smaller cup. So basically even a small size cupping in a case of a small disc is seems to be significant than that of a larger disc. So subtypes of the glaucomatous damage: 4 morphological glaucomatous disc appearance have been described, and although the majority of the discs are unclassified, the description encompass a useful overview of the pattern of glaucomatous damage and may provide clues to the underlying pathological process. So basically there are certain kind of morphologically or anatomical changes that occur with the glaucomatous disc. Number 1 is a focal ischemic disc. It is characterized by localized superior or inferior notching and are associated with localized field defects with early threat to fixation. So basically you know that inferior and superior rim are the thickest, and basically that is why the vertical cup disc ratio is more important, because the superior and inferior retinal rims tends to have a more defect, like there will be the localized notching. So this will call the notching, and these are the focal ischemic defects. Myopic disc with glaucoma refers to a tilted, obliquely inserted, shallow disc with a temporal crescent of a parapapillary atrophy, together with the feature of a glaucomatous damage. Dense superior or inferior scotomas threatening fixations are common. This morphologically is sometimes common in younger male patient. So basically you know a myopic disc is usually that which is a tilted disc, and basically it have a very shallow disc, like not very much very much like clear margin. It will have a tilted appearance, and there will be a very small cup. So if this such kind of disc is having a glaucomatous damage, then it is also signs of a glaucomatous damage. uh, Next is a sclerotic disc. Sclerotic discs are characterized by the shallow saucerized cup with the gentle sloping of the neuroretinal limb, variable peripapillary atrophy, and peripheral visual field loss. The peripapillary choroid is thinner and another disc type. Patients are older and of if either gender, and there is an association with the systemic vascular disc. So basically there will be the cup will be very shallow and saucerized, and you will not see that a cup with a very distinct margins. So you can see this figure here. So A is showing us notching. Focal ischemia, there is an inferior notching like this. You can see that there is a little bit of notching. Myopic disc with a temporal crescent and the superior notching. So this is a B is showing us a myopic disc. It is a slightly tilted disc with not so much distinct margins of the disc, and you can see that there is a superior notching that is present here, which is not very clear. uh, an inferior notching as well, superior notching. C is showing sclerotic with superior shelving and inferior notching. So this is showing a sclerotic disc, which is not so much of a, like distinct margins, but there will and slightly sloping of neuroretinal rim, and there will is an inferior notching as well. And D is showing us a concentrically enlarged uniform deep enlargement of the cup. So cup is deep and enlarged. Concentrically enlarging discs verified by serial monitoring are characterized by the fairly uniform NR thinning and are frequently associated with diffuse visual field loss. IOP is usually elevated at presentation. Non-specific signs of the glaucomatous damage. Other disc signs of the glaucomatous damage include disc hemorrhage are often extend from the neuroretinal rim onto the retina. Most common infratemporally, their presence is a risk factor for the development and progression of the glaucoma. They are more common in normal tension glaucoma, but can also occur in healthy individual as well as patient with the systemic vascular disease. When screening for glaucoma, approximately 3 out of 4 people with the disc hemorrhage will not have a glaucoma. So basically, non-specific sign is that sometimes there is a disc hemorrhage that is present in the infratemporal area. Basically, if a glaucoma patient have a disc hemorrhage, it means that a glaucoma is progressive, and most likely it occur in a case of a normal tension glaucoma, but sometimes it occur in a normal patients as well. So this is a disc hemorrhage. A and B is showing the disc hemorrhage. So this is a disc hemorrhage and this is a disc hemorrhage. Next is the bearing of the circumvenial blood vessel is an early sign of the thinning of the neuroretinal rim. It is characterized by the space between the neuroretinal rim and the superior blood vessel. So basically it is a dipping of the blood vessel. So whenever that a the blood vessel is going, it has a slight dip because of the thinning of the neuroretinal rim. It is called the bearing of the circumlinear vessel. So you can see that there is a slight dip in a case of uh, uh, this glaucomatous damage. Next is a bionating is characterized by the double angulation of a blood vessel with neuroretinal rim loss. A vessel entering the disc from the retina may angle sharply backward into the disc and then run towards its original direction to run across the lamina cribrosa. So basically it is having a zigzag type appearance. It have a double angulation, like it is happening that the disc is entering and then it will go towards the disc and then it is going towards its normal course direction. Next is collateral between the two veins at the disc, similar to those following central retinal vein occlusion, are relatively uncommon. They are probably caused by the chronic low-grade circulatory observation. Retinal vascular tortuosity may also occur. So this is a collaterals. So collateral is between the two veins, and it is very common in the case of a CRVO, post CRVO, and glaucoma as well. The loss of the nasal neuroretinal rim is a sign of moderately advanced damage. A space may develop between the neuroretinal rim and the central retinal vasculature. The lamina dot sign occur in advancing glaucoma. The gray dot-like fenestration in the lamina cribrosa become exposed as the neuroretinal rim recede. The fenestration sometimes appear linear and itself may be a sign of advanced damage indicating distortion of the lamina. The dots may be seen some in a normal eye. So basically, that sclera has a slightly porous structure which allows the optic nerve to pass through it. Nerve bundles to pass through it. So whenever there is a damage to these nerve fiber, there will be the appearance of the dot signs, which is about a gray in appearance, which is known as a laminar dot sign. So you can see here E is showing collateral vessel, F is showing the laminar dot sign, which is not very clear in this case, arrow and nasal cupping associated with the uh, glaucomatous damage. Sharpened edge or sharpened rim is a sign of advancing damage as neuroretinal rim is lost. Adjacent to the edge of the disc, the disc margin control disc margin control assume a sharper angle backward. Bionating of the vessel is often seen at the sharpened edge. So basically, sharpened edges when the neuroretinal rim is almost at the level of the uh, disc margin, then there will be like a very sharpened appearance of the disc, and there will be the bionating of the vessel at this point as well. This should not be confused with the sharpened nasal polar edge, which refers to the sharp angulation of the neuroretinal rim at the nasal margin of a focal vertical polar notch. Optic disc hemorrhage is a risk factor for the development and progression of glaucoma and can be missed unless magnification is used to examine the disc. Next is a peripapillary changes. Basically, this is the change around the disc. Peripapillary atrophy surrounding the optic nerve head may be of significance in glaucoma and may be the signs of the early damage in a patient with ocular hypertension. So, basically, it is a significant in a glaucoma patient, and it also occur in a case of a ocular hypertension. It is the first sign of the glaucomatous damage. Alpha outer zone is characterized by the superficial retinal pigment epithelium changes. It tend to be larger and possibly more common in glaucomatous eyes. So, if there is a peripapillary atrophy and there is a zone alpha, it means that there is a more uh, uh, likely to be the patient is more likely to be of a glaucomatous. Beta inner zone is characterized by the chorioretinal atrophy. It is distinct from the scleral limb. The wide band of the sclera central to the beta zone. The beta zone is larger and more common in glaucoma and is a risk factor for progression. So it is also a risk factor for progression because the beta is, so the beta is basically the outer rim, which is due to the retinal pigment epithelium changes, pigmentary epithelium changes, and it is tend to be more common in case of glaucoma. And in a case of beta zone is basically the chorioretinal atrophy is occurring, and it is inside the alpha zone. And if the patient has a larger and a more more of it, it means that it is progressing glaucoma. The location of the beta zone peripapillary atrophy seems to indicate the orientation of the likely visual field loss. Then there is a retinal nerve fiber layer. An understanding of the distribution of the 1.2 million ganglion cell axon as they pass across the retina to the enter the scleral canal to form the optic disc is the key to the interpretation of the visual field loss in relation to the optic nerve cupping in glaucoma. Within the retina, the arrangement is as follows. So basically, you have to understand that that this is a disc and this is cup. So which area of the which side of the optic nerve is having which kind of the nerve fiber layers? So for example, the nasal side of the optic nerve is uh, and the nasal side and the temporal side of the retina is having a nerve fiber layer that is crossing the midline, the horizontal referee, and they're going straight to the nasal and the temporal side. Whereas then there is a superior arcuate fibers, nasal arcuate fiber, and then there is a temporal arcuate fiber superior, and there is a nasal inferior arcuate fibers. So they surrounds the superior and the inferior regions. So fiber arising from the macula follow a straight course to the optic nerve head following a spindle shaped area. So basically those which are arising from the macula is just going straight, and they are going to the uh, nasal part of the temporal part of the optic disc, which is fiber arising from the nasal retina also follow a relatively straight course to the optic nerve. So the nasal retinal fiber also have a straight course, and they are at they end at the nasal side of the optic disc. Fiber arising from the temporal to the macula follows an arcuate path along the papillomacular bundle to reach the optic nerve head. They do not cross the horizontal raphe that extend from the fovea to the temporal retinal periphery, demarcating the superior and inferior half of the retina. The arcuate fiber reaching the supratemporal and infratemporal aspect of the optic nerve head are more vulnerable to the glaucomatous damage. The fibers in the macular bundles are more resistant. So next is the arcuate fibers. So basically these are the temporal arcuate fibers, superior temporal, and these are inferior temporal, and they are at the superior and inferior margins, and they are the most common to be disrupted in a case of a glaucomatous damage, whereas the papillomacular bundle is the most resistant one. In the papillomacular, within the optic nerve head, the nerve fiber, retinal fibers are arranged as follows. The fibers from the peripheral fundus lie deep within a retinal nerve fiber layer that is nearer the pigment epithelium but occupy the most peripheral superficial portion of the optic nerve portion of the optic nerve. The fiber arising from the optic nerve lie superficially within the nerve fiber layer near the vitreous, but they are occupy the most central portion of the optic nerve. So this is the picture basically which is showing us that fibers that is more in the periphery are deeper in the nerve fiber layer, whereas in the optic nerve they are superficial, whereas in the case of a fibers closer to the optic disc are more superficial, but they are deeper in a case of a optic nerve. So in glaucoma, subtle RNFL defect precede the development of the detectable optic disc and visual field changes. They also often follow the disc hemorrhage. So first of all, if there is a very much RNFL defect and RNFL thinning, then there will be the appearance of the visual field loss. True patterns occur localized wedge-shaped defect and B diffuse defect that are larger and have an indistinct borders. Uh, Defects are sometimes evident following disc hemorrhage. So basically it is talking about the RNFL defect. So they can be like a wedge shaped defect, like we can see in the red field there, or they can be the diffuse defect as well with the indistinct border. Red free green light increases the contrast between the normal retina and defect on the slit lamp biomicroscopy or the fundus photography, and typically makes the identification easier. Optical coherence tomography, OCT, and the scanning laser polarimetry are highly effective means of quantifying the RNFL. It should be noted that RNFL defects are not specific to glaucoma and can be seen in a range of a neurological disease as well as in apparently normal individuals. So basically, it is trying to say that we can see this kind of defect in the red free filter or green filter, and what you can see is a wedge shaped effect. And now there are certain investigations like OCT and this scanning laser polarimetry which can detect the RNFL thinning at an earlier stage before there is a any fundus appearance. So we can see figure 11.15. It is showing the RNFL defect. A is showing the red free photograph, so you can see that there is a wedge shaped defect associated with the disc margin hemorrhage. B is showing the corresponding superior arcuate defect in the visual field. So you can see that if there is a defect in a nerve fiber layer, the visual field will be the opposite to that side of the will be affected. For example, if it is the infro nasal area that is affected, then the visual field loss will be the supratemporal area. And this is showing the OCT, showing the thinning of the nerve fiber layer in the upper temporal area. So you can see the upper temporal area is having a thinning in a OCT. Imaging in glaucoma. So what a kind of imaging can be done in a glaucoma? Imaging has become an indispensable tool in the management of patient with glaucoma. However, it is important to remember that in order to determine a diagnosis or to determine change, imaging should always be used to supplement clinical examination and visual field result rather than as a sole investigation. So basically, in glaucoma, everything complements each other. For example, IOP, visual fields defects, plus any OCT, all of them complements each other and make us helpful in a baseline investigation as well as in a case to establish our diagnosis. So pachymetry is very important because you know that having a low CCT will give us low IOP, whereas high CCT will give us a higher IOP. So you can apply the correction factor accordingly and you will know about the correct IOP of the eye. So the measurement of the corneal thickness is an essential part of the assessment of the glaucoma patient. Stereo photography has historically been regarded as a reference standard in optic disc imaging and remains a valuable option. The images are taken by repositioning slightly between the shots, either manually or using a stereo separator built into the camera. So basically you can just take a photograph of the fundus, and during each visit you can take a photograph and you can compare how much the optic disc has or optic cup has been changed. Ultrasound biomicroscopy. This is a type of ultrasound that creates a more detailed image than a regular ultrasound and is used for the imaging the interior segment of the eye. This result in resolution up to 25 micrometer axially and 50 micrometer laterally, but the depth of the tissue penetration is less than this. It is particularly useful to show the anatomy of in a patient with a primary angle closure glaucoma in comparison to the anterior segment OCT. The main strength of the UBM is its ability to demonstrate structure behind the iris, particularly the ciliary body and the lens. So basically, UBM is an ultrasound technique that captures the interior segment of the eye. So it what resolution it has a frequency it use. It will give the resolution about 5 micrometer axially and 50 micrometer laterally. So what happen is how it is more superficial than more superior than OCT, because it has more penetration. It will show us the structure behind the iris, which is ciliary body and lens, and you can see the angles of with the help of this, and you can know that it is a clear open angle, closed angle, or there is any kind of a plateau iris. So UBN of the interior segment showing a normal angle appearance, so you can see that angle are open. This is iris, this is cornea, and angles are quite open. And B is showing us the closed angle in with the ultra biomicroscopy. Next is the optical coherence tomography of the interior segment. Remember that OCT can be done of the interior segment as well as posterior segment as well. So in the case of interior segment, it will give us the detailed structures of it can also show us about the angles, but it will not give us more details of the lens and the ciliary body. So interior segment OCT has an expanding range of clinical application, particularly in the evaluation of the angle closure glaucoma. It is useful when demonstrating the relationship of the peripheral iris to the filtration angle. So this is the OCT of the peripheral iris. A is showing us a thickened iris, B is showing abnormal iris insertion, C is showing peripheral iris roll on pupil dilatation. Interior chamber depth measurement. Objective measurement of the depth of the interior chamber is often clinically useful in the glaucoma management. Inclusion indication include the assessment of the primary angle closure risk and monitoring of the progression in condition where the AC is shallow, such as post-trabeculectomy, hypotony, and cilio-lenticular block. So you can measure the anterior chamber depth, and you can know that if there is a suspected angle closure, then how much chance is that the patient can have a primary angle closure. Older method used a slit lamp without special attachment, but an accurate and repeatable Measurement can be obtained using OCT, ultrasonography, or optical interferometric methods. These I will master. So there are investigation techniques which can measure the AC depth, but sometimes we can measure with the methods like Smith's method to see the AC depth. The optical coherence tomography of the posterior pole. Optical coherence tomography is most useful when the patient is either a glaucoma suspect or has an early to moderate disease. It can be used to detect damage and progression. In advanced glaucoma, it is less helpful because of the floor effect. When the retinal nerve fiber layer reaches 45 to 50 micrometer, it does not decrease any further, even though progressive damage may be occurring. So basically, it has a role in early glaucomatous damage when we are not sure that how that is it glaucoma or not. Is there RNFL thinning? So we can do OCT of the optic nerve head to see about the RNFL thinning. But one thing is that in advanced cases it is not much of the helpful because of when the nerve fiber layer reaches 45 to 50 micrometer, it will not show any other further progression. Macular thickness measurement may be more helpful in these circumstances. Sensitivity and specificity utilizing a comparison with the normative databases as high as 90%. Peripapillary RNFL. This involves the acquisition of the circular scan of the retina around the optic nerve head. Because different OCT devices uses a different scanning protocol, caution should be taken when comparing RNFL thickness between the machine. By using this, by using the Brooks membrane opening rather than an optic disc margin, centration of the image can be enhanced. The results are compared to a color coded normative database. When assessing structural changes over time, it is often difficult to distinguish between the glaucomatous change and measurement variability or age related structural loss. Up to 4 micrometer um, intertest fluctuation has been reported. A new defect, widening of an established defect, or a deepening of a defect are important features of the glaucomatous change. So basically, it is discussing about the RNFL thinning. So what is scan OCT is doing that it is basically taking the peripapillary RNFL measurements. So how it takes is basically that it around the center of the optic nerve head, around it measures the RNFL thinning, and it will take Brooks membrane as it point, because Brooks membrane is at that level where the optic disc starts. So it is quite centered around it. And remember that if a patient has an OCT scan and he comes again and you do a different OCT scan, so machine to machine variability matters. And also sometimes the 4 micrometer thickness also matter even if the same machine is used. So if there is when you see a follow-up patient and you do repeat the scan, if there is a new defect, widening of a defect, or a deepening of a defect, it means that there are glaucomatous changes occurring. Optic nerve head radial cross-sectional scan permits an objective and repeatable assessment of a disc morphology with reasonable discriminatory values. This function is less well commonly used than RNFL. Ganglion cell complex analysis involved a measurement of the thickness of the RNFL, the ganglion cell layer, and the inner plexiform layer at the macula in an attempt to detect the early glaucomatous damage. This is an effective for diagnosing glaucoma and assessing progression as analysis of the RNFL. OCT signal quality is good, particularly in elderly and diseased eye. It should be considered supplementary to RNFL assessment. So basically, in a case of ganglion cell complex is basically an early is to detect the early changes in the glaucoma. So what you do is basically you measure the thickness of the three layers in the macula. One is the ganglion cell, another is the nerve fiber layer, and the inner plexiform layer. And if by measuring the thickness you can detect the glaucoma. So progression analysis software has been introduced on several machines and provide a computed assessment of the extent of the damage over time. Trend-based analysis using a number of scan measure the shape of change and is particularly useful when confirming the progressive changes has occurred. So basically it is there are certain software that is installed in OCTs to check about the progression of the disease in a same patient. Tip: OCT imaging of the optic disc should not be used in isolation but rather to supplement the finding of a clinical examination. So basically OCT is just to supplement the finding. So these are some of the imaging which of the OCT of the optic disc showing RNFL thinning above and below the disc on the right, and the left disc show no abnormality. So the if the optic disc is on right, it means that you are seeing the optic OCT of the right eye, and so these are two OCTs. This is of the right eye, this is of the left eye, and the right eye is showing the thinning of the RNFL. You can see that there is a thinning of the RNFL in the temporal area. There is a nasal there is a superior and the inferior and or below the normal, and temporal area is borderline, whereas this one is normal, so it will have further division into the temporal area, supratemporal, temporal, ti, infratemporal. So it is showing also the thinning of the layers, and in the case of the left side it is all normal. So this is also showing the OCT of the optic disc. A is at presentation, B is after 2 years showing progressive RNFL thinning. So it is a baseline investigation, and you follow up the patient after 2 years, you can see that there is more increase in the damage. So you can see more progressive damage. Next is a confocal. So this is also an glaucoma protocol OCT showing the optic nerve head, peripapillary retinal nerve fiber layer, and the ganglion cell. Uh, this is showing the ganglion cell complex, and this is showing the thinning. This is of the right eye, this is of the left eye. The left eye is showing the ganglion cell is thinned in this case. So confocal scanning laser ophthalmoscopy. This employs a scanning laser ophthalmoscope to build a three-dimensional image of the optic nerve and head and the retina. So it basically have a 3D image of the retina, and it will detect the optic nerve changes. So the Heidelberg retinal tomography is still in widespread clinical practice but has been superseded by the OCT. So basically now we perform OCT. This is rarely used, as with the OCT is used to distinguish normal from the glaucomatous eye by comparison against a normative database. So we have some normal data that is installed in the already machine, and so you compare it of the patient's data with the normative data, and you can monitor you can diagnose the disease and know the disease progression. Keratometry values must be entered in significant greater than 1 diopter astigmatism corrected by the means of a cylindrical lens. High quality images can usually be acquired without pupillary dilatation and through mild to moderate lens opacity. After image capture, for greater accuracy, the operator should manually mark the contour line that defines the edge of the neuroretinal rim. Um, Image data analysis can be examined on computer screen or print out detailed stereometric data are presented with abnormal readings identified. So this is a Heidel retinal tomographer of the glaucomatous eye. So it is giving us a 3D image of the eye, and the operator has marked the optic disc margins, and now the different readings are given, and the detailed optic disc values are being given, and you can see that if there is a damage or not. Then there is a scanning laser polarimetry. The glaucoma diagnosis variable corneal compensation RNFL analyzer assesses the nerve fiber layer thickness by using its birefringent, resolving or splitting a light wave into two unequally reflected or transmitted waves. Uh, Basically, nature to change the polarization of the incident polarized diode laser light. The amount of alteration is directly related to the thickness of the layer. So basically, polarization is basically when you hit the uh, some structure, then the certain wavelength is changed into another wavelength, and the how much difference is between them is give us the thickness of the layer. A display provide color image of the optic nerve head together with RNFL map in the four quadrants. Deviation map show location and magnitude of the RNFL defect as tiny colored coded squares, and parameter for each eyes are displayed in table. So this is a glaucomatous glaucoma diagnosis, and it is a variable corneal compensation showing reduction in the retinal nerve fiber density in the eye, right eye, and abnormal parameter. So in the table you can see the abnormal values in the red, and you can see the RNFL thickness. A global value based on the entire thickness map is optimal parameter for discriminating normal from glaucoma. So that's it for the part 2, glaucoma part 2 4. See you in the next lecture.